Assalamu alaikum everyone. Um,
Assalamualaikum Rasadia.
Walaikum assalam. I thought everyone can hear me.
Yes, you are
Okay,
audible.
Bismillahirrahmanirrahim. We'll start the session. I welcome you all on behalf of PSA to this online PSA lecture series. And today our topic is airway and respiratory complications during the cardiac NORA. And our presenter for today will be Dr. Muhammad Saad Yousuf, and he's working as an assistant professor at Khan University of Karachi in anesthesiology department. Before we start, there are some general rules we all have to follow. Uh, the conversation mode will be in English because we have international participants as well. So I request you all to just keep the conversation in English. And I request all of the participants to please keep your mic and your videos off to run a smooth lecture. And if you have any queries or any questions, you can just post it in the chat box and we'll take them one by one at the end of the lecture. I'll hand over to Dr. Saad. You can start.
Thank you. Thank you so much, Dr. Sadia. The topic of my today's presentation is on airway and respiratory complications during cardiac non-operating room anesthesia. Basically, I will move from the big picture, started from the big picture of non-operating room anesthesia safety problems. Then I move to the procedure-specific examples, which I mainly focus on the transcatheter aortic valve implantation, which we call TAVI procedures, electrophysiological ablations, which include the atrial fibrillation ablation and the pulmonary vein isolation, and the left atrial appendage occlusion. And then finally, we will move to the practical prevention and rescue framework, which you can use daily in your practice. Why this topic matters? So basically, because more complex cardiac procedures are moving outside the traditional OR into the cath labs and EP suites and the hybrid spaces. So these patients are often older, like 3.5 years more age as compared to the OR patients. They are more frailer and they are having more comorbids, having ASA 3 and 4 about 37.6% as compared to the patients in the planned in the OR. So the environment is usually so less forgiving for the airway rescue. So the literature basically suggests the NORA may represent a very large population of future anesthesia workload. So why cardiac NORA is different? So basically, the cath lab and the EP suites were built around the procedure, not related to anesthesia. So access to the airway is restricted in these areas by the fluoroscopy equipment, drapes, and the operator position. And many cases are short and high intensity, and they are time sensitive. So basically, that is what we call the cath lab as a sprints rather than the OR marathons. So what basically the pathway of respiratory failure in these type of outside OR localities? So basically, deeper the sedation, the more the upper respiratory obstruction and hypoventilation took occur, and difficult to rescue. So because access and team familiarity are very limited in that area. So the message is in cardiac NORA, basically in cardiac NORA, the safest plan is not the sedation first or the GA first. So it is the plan with the best fit between the procedure, patient monitoring, and rescue readiness. So the combination of high-risk patients, limited head and access, and the frequent deep sedation makes the respiratory failure one of the most relevant threats in the modern cardiac non-operating room anesthesia. Now, these are the objectives of the talk. So first, we understand why airway and respiratory events matter so much in cardiac NORA. Second, we move on to identify the patient's procedure and environment factor that increases the risk. Then third, we translate the evidence from the attached paper into the practical planning, like who may tolerate the sedation, who needs more support earlier, and what type of rescue steps should never be delayed. Now, NORA hazard map. Now, this hazard map is useful because the respiratory complication almost never come from one isolated cause. So, usually several weaknesses align. The patients may be elderly, frail, obese, or having history of obstructive sleep apnea, having COPD or heart failure. So, the procedure may require immobility, trans-esophageal echo tolerance, pain control, or breath control. Then the environment adds the restricted access, noise, dim lighting, unfamiliar staff, or delayed backup. And when these are combined, even the small airway problems such as snoring or hypoventilation can rapidly progress. So prevention must be system-based, not only the patient-based. So the shared final pathway is the deeper the sedation, the more is hypoventilating, the more obstruction will occur. There are more chances of aspiration, and there will be a problem of delayed rescue. So why airway and breathing dominates serious harm? So across the NORA reviews, and which I came across mainly the NORA reviews and claim analysis, the recurring themes are around the oxygenation failure, inadequate ventilation, aspiration, and oversedation. So importantly, these events are often judged preventable. That means many respiratory disasters are not the inevitable consequences of disease severity. They are failures of planning, monitoring, recognition, or rescue. So for teaching purposes, this should shift our mindset from reacting to desaturation alone towards recognizing earlier warning signs such as obstructed breathing, increased airway support requirement, or poor ventilation trends before the patient crashes. So why these events happen? So deeper the sedation is common. They are often without a secured airway. So procedure complexity can escalate faster than the airway plan, and inattention or hassle or unfamiliar equipment magnify the small errors. So it's better. So the final is the better the monitoring earlier the escalation appear repeatedly as preventable points. So what are the implications for all of these in the cardiac NORA? So the question is not only simplify whether the spontaneous ventilation is possible at induction, it is whether it remains reliable during the painful moments, long procedures, TOE manipulation, and the sudden loss of access to the head end. So, sedation in cardiac NORA is a continuum, not a fixed category. So there was a case planned as a moderate sedation can easily drift into a deep sedation, especially when discomfort, movement, TO intolerance, or procedure delay leads to repeated top-ups. So the most important point in this slide is that the airway plan must be linked to the deepest level the patient is likely to reach, not the level we initially intend. So before starting, define a clear threshold for rescue escalation. When will you move from simple oxygen to the airway agents, then towards the supraglottic support, and then finally to the general anesthesia? So the decision should never be improvised late. So the rule is simple: prepare every sedated cardiac NORA patient as if its conversion to GA could become necessary at any time. So different cardiac procedures challenge the airway in different ways. So in TAVI, like transcatheter aortic valve implantation, it basically attracts the sedation because it may preserve the hemodynamics and speed of recovery. But frail elderly patients having hypoxemia, having hiccups during the procedure, or snoring, or painful moments, prolonged immobility, these are all the threatening for the airway or breathing. So, and so the common reason to escalate the support during the procedure are the body movement, obstruction during the procedure, desaturation, and the need for TOE or rapid conversion. So, in electrophysiological ablation, like in atrial fibrillation ablation, they often need prolonged immobility, and even the brief hypoxia or patient movement can destabilize the mapping system and interrupt the procedure. And while in the left atrial appendage occlusion, it may be feasible under conscious sedation in selected centers, but TOE tolerance and aspiration risk remain critical concern. So rather than asking which technique is more common, is more fashionable, so ask what this specific procedure demands from the airway for its full duration. Now, basically, this slide summarizes who is most vulnerable for the respiratory risk. So recurrent themes across the paper which I came across includes old age, as I mentioned earlier, old age, frailty, obesity, increased neck circumference of greater than 40 centimeter, sleep-altered breathing, tiredness, suggestive of OSA, COPD, and reduced baseline oxygen reserves. So these are all the patient-related risk factors in which the respiratory risks are very high. While the procedure-related risk rises with the longer sedation, painful steps during the procedure, TOE use of TOE guidance, and the strict need for immobility. So, while the environmental factors such as poor lighting during the procedure, cramped spaces, limited space, and inconsistent staff familiarity further narrow the safety margin. So, the practical message is that a focused airway and respiratory screen should tailor to the procedure is more useful than rely on the ASIC class alone. So the practical screening before starting the procedure, you should ask, can the patient tolerate the planned position and duration? Is there evidence of OSA or COPD or frailty? Will the airway remains accessible if the case become urgent? And if any answer is no or maybe, then escalate the airway plan before the first step. So now we will move to the specific procedure. So TAVI basically is a good example of the tension between the sedation benefit and the respiratory vulnerability. So this is the series which we done here in AKU by Dr. Akbar and me and Dr. Khalid Siddiqui and Khalid Samad. We all were involved in this study. So in this series, we did the retrospective analysis and we found that the patients were mainly the elderly and many had significant comorbidities. While some cases were performed under general anesthesia, while other under the MAC, reflecting real-world heterogeneity. So the low overall complication rate is reassuring, but the need for post-operative ventilation in a subset remind us that the respiratory reserves can be limited and deterioration may carry serious consequences. So, in TAVI, sedation can be attractive, but only when combined with careful selection, close monitoring, and be ready to escalate the support. So, the clinical pearl from the attached TAVI paper was that the sedation is not inherently safer than the GA. It is safer only while oxygenation, ventilation, and immobility remain acceptable, while in high-risk patient, airway support must be ready before the first puncture. Now, use of high-flow nasal oxygen as a bridge in selected TAVI cases. This is the case report which I came across in which the Osawa et al. Illustrate that how oxygenation support can preserve a sedation strategy when the airway is the weak link. So in this case, this is the case of 82-year-old frail patient with severe aortic stenosis, having heart failure, hypoxemia, and hiccups, underwent planned TAVI under sedation with dexmedetomidine, fentanyl, and ketamine. Now the problem arose during the procedure was there was a hiccups and body movement, which threatened the procedural precision, adding more sedative analgesic risk, the upper respiratory obstruction, and respiratory depression. So what this strategy contribute? So basically, they mentioned that it supported the oxygenation, helped suppress the hiccup associated movement, and avoided the conversion to GA. So interpretation was that it can be used as an adjunct, but not a substitute for airway vigilance. So the best use is selected frail patients with the marginal reserves who may still benefit from the spontaneous ventilation, provided rescue equipment and conversion capabilities are immediately available. Now, the atrial fibrillation ablation literature makes the respiratory problems very concrete. So there was a study which was done by the Homburg in which they found that the respiratory complications during procedural sedation and analgesia were common, around 42.2%. And that matters because in the electrophysiological work, airway instability is not just a physiological issue. It also affects the procedural quality, catheter stability, and the case duration. So the predictors, as I mentioned earlier, such as the large neck circumference, OSA-related features, COPD, and longer sedation can help identify patients who planned procedural sedation analgesia may become difficult. So this type of ablation is one of the clearest settings where pre-procedural respiratory risk assessment can directly influence whether sedation remain appropriate or not. So the implication of this study is that if strict immobility and longer duration are expected, a low threshold plan for airway support is often safer than repeatedly topping up the sedation to chase the motion and discomfort. Now, when deeper support helps. So, at what time that we use the supraglottic airway during atrial fibrillation ablation? So, there is a study which was done by Heda et al. Especially, basically, it's a useful study because it shows that the airway support can improve not only safety but also procedural efficiency. So, when a supraglottic airway was used during deep sedation for this ablation, hypoxia fell from 15% to 0%. MAP dislocation decreased from 31% to 8%, and procedural related time also improved. So that suggests a supported airway may reduce the repeated interruptions, patient movement, and rescue maneuvers. So the broader lesson is important. Sometimes escalating airway support earlier is not a failure of sedation. It may be more controlled and efficient way to deliver the intended procedure safely. So the message for this practice was that when the ablation accuracy depends on immobility and the patient has limited respiratory reserves, so more airway can be the more efficient choice, not only the safer choice. Now, at the same time, these slides remind us not to oversimplify. Conscious or deep sedation can still be safe in selected electrophysiological patients when the monitoring and protocols are adequately appropriate. There was a study which was done by Winman, and he used structured sedation and added the transcutaneous carbon dioxide monitoring during the procedure, which is valuable because pulse oximetry alone may miss early ventilatory failure. So the question is not sedation versus airway support as absolute. The question is whether the depth, duration, monitoring, and rescue capacities are matched to the specific EP procedure and the patient's respiratory reserve. So the goal is to match the sedation depth and monitoring to the procedure, not to force one model for every case. Now, the left atrial appendage occlusion study shows that the conscious sedation without an anesthesiologist on site can be successful in selected high volume centers with high procedural success and no reported respiratory failure was reported needing ventilation. However, this should be interpreted carefully. The finding supports feasibility in an experienced system, not the universal safety in every center. So for us as an anesthesiologist, the key message is that patient selection and system design matters enormously. So TOE tolerance, aspiration risk, and local rescue capacity should determine how far one can safely simplify the airway plan. So, what type of monitoring? So, monitoring can be used. So, monitoring should be designed to detect respiratory failure before the oxygen saturation falls. Pulse oximetry is essential, but it is often a late marker if supplemental oxygen is being used during the procedure. Other minimum essentials include ECG, non-invasive or invasive blood pressure monitoring, reliable oxygen source, or backup available, reliable suction, self-inflating bag available with a capability of greater than 90% of oxygen, and the adequate drugs and equipments. So while the ventilation-focused tools should include the capnography or use of transcutaneous carbon dioxide can reveal the hypoventilation, obstruction, and sedation drift earlier. While the environmental checks are also equally important, uh, so you can ask, can you actually reach the head? And once the drapes and fluoroscopy are in place, if suction is available and working, is the back mask immediately usable when required? So in cardiac NORA, good monitoring means both physiological surveillance and confirmation that rescue the logistics truly work in the room. So this slide is about choosing the least invasive airway that will remain reliable for the whole case. A nasal cannula may be enough for short, low-risk operative cases, while oral or nasal airways are vulnerable, are valuable, basically, are valuable in early rescue tools and should not be seen as a failure. While the high frequency nasal oxygen can improve oxygenation margin in the selected patients, especially in the frail or hypoxemic patients, while the use of supraglottic airway may be the better option when deeper sedation is required, when the duration of the procedure is longer, or the immobility required during the procedure, which make repeated obstruction likely. And finally, GA and the use of endotracheal tube. So some patients are better served by securing the airway from the beginning rather than escalating stepwise after multiple warning signs. So escalate early means repeated rescue maneuvers means that the original plan is no longer the best plan. Now, drug strategy principle. So basically, it should follow the airway plan. A common error in NORA is to chase the movement or discomfort with the repeated sedative boluses while ignoring that the airway is progressively becoming the limiting factor. So across the attached papers, as I mentioned earlier, different regimes were used. But the shared lesson is titration with respiratory awareness, which is most important. So use the minimum effective depth, avoid over-sedation creep, and GSS, whether the procedure has outgrown the original airway plan. So in other words, when the patients keep needing more support, ask whether the problem is inadequate analgesia, inadequate airway strategy, or a mismatch between the patient and the planned sedation model. So the practical pearl is that once airway adjuncts oxygen demand or carbon dioxide trends suggest instability, so change the airway strategy is usually more effective than simply changing the sedative doses. Now, the prevention bundles before incision or puncture. So this prevention bundle is is meant to be practical, and it is very practical. So before puncture or incision, match the anesthetic plan to the real demands of the case. So screen for the OSA, COPD, obesity, frailty, baseline oxygen need, and poor exercise tolerance. Then test physically the airway access after positioning and draping, not only before the setup. Then prepare the next airway step in advance, including adjuncts, high frequency nasal oxygen if relevant, suction, and a clear conversation plan. So basically, this bundle is simple, but it addresses the main preventable problems which is described in the various NORA reviews and the procedure specific cardiac papers. Now, how to early recognize the impending respiratory failure. The early clues includes the snoring, paradoxical breathing, rising work of breathing, increasing jaw thrust requirement during the procedure, or rising CO2 levels, or reduced ventilation waveform quality, need of more oxygen to maintain the saturation during the procedure, repeated motions or agitation during the procedure, while the late clues includes the hypoxemia, marked hypercapnia, bradycardia or hemodynamic instability, aspiration or regurgitation, procedure interruption or the emergency conversion. So the teaching message is that the desaturation is often not the first sign of trouble. It is the point at which the earliest signs were missed, minimized, or normalized. So excellent rescue usually begin before the monitor alarm becomes dramatic. So what are the rescue algorithm for the obstruction or hypoventilation in cardiac neural? So this rescue algorithm should be thought of as a sequence, but also as a mindset. So first, announce the problem, and if possible, pause the stimulation. Second, open the airway with repositioning, jaw thrust, use of adjuncts, and do it suction. Third, optimize the oxygen delivery and verify that monitoring is reliable. Fourth is assess the ventilation if needed and reduce or stop the sedative administration. Fifth is to escalate early to a supraglottic airway or tracheal intubation when repeated rescue is required. Ventilation, or if the ventilation is inadequate or aspiration is suspected, or if the access is becoming impossible. So delay is usually more dangerous than the escalation. So the key decision is, after initial rescue, ask, is the airway now reliable enough for the remainder of the case? If not, then escalate. Now, these are the procedure-specific take-home pearls. So, as we discussed, intravenous sedation may protect hemodynamics, but respiratory reserve is often narrow, and sudden movement can be procedure threatening. While in atrial fibrillation ablation, in EP studies, airway stability improves the procedural stability, and supported airways may reduce the map shift and interruption. While in left atrial appendage occlusion, conscious sedation can work, but the use of transesophageal echo tolerance and the aspiration consideration remains the central. So, although the environments differ, the common principle is the same. The better the airway plan fits the procedure's real demand, the safer and more efficient the case becomes. So this final framework is intended for decision making. So sedation alone is reasonable when the patient has acceptable reserves, low risk of aspiration, monitoring can detect drift early, and rescue access remains realistic. So choose the supported or secured airway earlier when the TOE tolerance is uncertain, repeated obstruction is likely, the procedure requires strict immobility, or the room layout makes emergency rescue difficult. So the single sentence which I want you to remember is in cardiac NORA, the airway plan is not backup to the sedation plan. It is the core strategy that determines whether sedation remains safe and reproducible. So, this is my final slide of my presentation. So, basically, these are all the references which helped me in making this presentation. So, I would like to highlight these three groups of paper. First, broad NORA safety reviews that explain the systems risk. Second, the closed claims and narrative safety literature which shows why respiratory events are so prominent and preventable. And finally, the cardiac procedure related papers, as I discussed in TAVI, EP ablation, and left atrial appendage occlusion, that makes the discussion clinically concrete. So these references can be used later for the journal club discussions or protocol development or to adopt local airway and monitoring pathways in your own cardiac NORA environment. Thank you.
Thank you, Dr. Saad. Your lecture was really informative and connecting to the cardiac NORA in the true sense. And I would like to invite for the questions. If anyone has a question, kindly comment in the chat box. If anyone from the seniors have a comment or they want to share their experiences, they can also just say a few words.
Yes, you can share anyone there are a lot of mentors here in the presentation, so they can share their what they have experienced in their centers as well.
Dr. Saad, we don't have any questions yet. We can wait for a few minutes and then we
Yeah,
can
sure,
conclude.
sure.
I just want to share one thing from
Yes,
my
please.
experience. I also work in a cardiac setup, and
Yeah.
specifically not related to TAVI or these procedures, but in the pediatrics also, where we are dealing with the small babies and we have to get the TE or the procedures or the device procedures done. Airway, again, I second your sentence that airway is not a backup plan. We have to decide either either we have to just keep them sedated, and many of the procedures we have to just go for GA. And during that as well, we experience in many children we experience that there is a bronchospasm and sometimes there is I personally experience in a few of patients laryngospasm as well while extubating. So we have to be very vigilant. And for the adults, your lecture was really insightful and very informative.
Thank you so much. I totally agree, Dr. Sadia. So it depends whether this cardiac NORA you are going to. So basically, the main theme is that, as you mentioned, as I mentioned in my presentation, the airway plan is not the backup. You have to first decide before the procedure, either related to the patient comorbids and the risk factor, either to go for the sedation or go for the general anesthesia. So we have to decide right in the beginning of the procedure rather in the middle or before it's been too late.
Obviously, being anesthetists, we are always ready for emergencies, but we must have a clear backup plan in our mind.
Yes, absolutely.
We have a question in the box, but it's not related to airways. Dr. Shahid Rasool is asking most common arrhythmias with NORA and common vasopressors used for hypotension. If you
So
can answer
basically,
that, because mainly our topic today was airway and respiratory
uh,
complications, but we can still.
so basically, the
Yeah.
arrhythmias in the NORA is mostly related to catheter related. Like it may be a sinus arrhythmias mainly, maybe atrial fibrillation. But it all depends upon the what the procedure is being doing at that. So it's all specific to that. And the vasopressors which we usually use, it also depends what are the conditions, what are the comorbid, what type of procedure is they are doing. So the vasopressors and inotropes decision will be decided on the basis of this.
Okay. Dr. Adil Ashraf has said sometimes monitoring becomes difficult, especially when dealing with the hemodynamics in stable patients. Invasive monitoring not possible most of the time. How can we overcome in such situations?
So basically, vigilancy. So be vigilant during the procedure. Uh, if the procedure is being doing under the conscious sedation or the deep sedation, you will have to monitor the end-tidal CO2 monitoring or non-invasive blood pressure, whatever the support of monitoring in your setup is, but be vigilant during the procedure.
Exactly. And one more thing I would like to add that if we go back to our basics, in
Yeah.
standard 2 monitoring, when we are monitoring with only non-invasive things, then we have to see the color of the patient, we have to see the breathing movements, we have to see the basic ECG and the everything that is appearing on the monitor. We have to be very much vigilant because standard one, we ourselves are standard one monitoring. So, if we are not sticking to our basics, then it would be difficult to move to the advanced or invasive monitoring. Even if it's not there, we can always use our vigilancy and our alertness in the course and
Exactly,
the
exactly.
NORA as well.
I totally agree.
Dr. Asma, would you like to comment something if you're here, if you're listening?
Thank you so much. It was a very well presentation, and thank you, Dr. Saad, on behalf of PSA, that
Thank you.
you have presented a very important, yet very less talk about topic on cardiac anesthesia or cardiac NORA.
Thank you, Dr. Asma. Thank you so much.
Thank you, Dr. Asma. I have posted the feedback form in the comment box. You can just fill it so
There
that
is
we
a
can
hand
address
raise.
it.
You can ask the question from Dr. Jasim. Probably he wants to ask something.
Okay,
Hello,
Dr. Jasim, if
everyone.
you want.
Hello, Dr. Jasim.
Thank, thank you for your nice presentation and valuable features. I just want to ask whether there are some predictors for to prevent complications regarding the airway. Pre-procedural,
Yeah.
pre-procedural tests that can predict complications.
So, Dr. Jasim, as I mentioned, the predictors, the most common, is all related to the patient, procedure related, and the environment. So basically, the procedure-related risk factors include the patients are more elderly, there's frailty, having neck circumference of greater than 40 centimeter, having history of OSA or COPD or heart failure, there is a most likely chance of airway or respiratory complication during the procedure. But if the procedure is also the prolonged and require immobility for a prolonged period of time and the use of TOE during the procedure, it also increases the risk as well. Hope I answered your question.
Okay, thank you very much. Thank you.
So, any other questions or any comments before we conclude?
I don't see any new questions, Dr. Saad, in the comment box. If anyone want to comment, you can comment. Otherwise, we'll conclude the session. I guess that's it. Thank you, Dr. Saad. Thank you very much for your lecture, and that's all for today. And we'll be joining in the next lecture, and we'll be, inshallah, meeting in the next lecture.
Thank you so much, Dr. Saad. Thank you so much, Dr. Saad.
Thank you, everyone. Thank you, everyone. Thank you, Dr. Saad. Thank you.
Allah Hafiz.
Thank you.
Allah Hafiz.